Good afternoon, and thank you so much for joining our educational session entitled The Physical and Emotional Toll of Breast Cancer. You are not alone. What rehab and exercise can do for you. Today's presentation is brought to you by My Style Matters in partnership with TurningPoint Breast Cancer Rehabilitation. My name is Tia Tomlin, and I'm the co-founder of My Style Matters, a 501c3 nonprofit organization serving cancer patients and their caregivers living in the greater Atlanta area. Before we get started, I would like to thank our sponsors for today's session, Amgen and Lymphedema. Lymphedema has kindly donated a $100 gift certificate that will go to the winner of our drawing at the end of this session. So good luck, everyone. I would like to thank our community partner, Turning Point Breast Cancer Rehabilitation. Today, you will be hearing from Turning Point's Mallory, Mark, and Jill Binkley. Mallory Mark is a physical therapist with Turning Point Breast Cancer Rehabilitation. She received her BS in Health Science from the University of Dayton in 2014 and is a 2016 graduate of Chatham University's Doctorate of Physical Therapy program. Following graduation, she worked primarily in rehab with both the neurologic and oncology population. Mallory is passionate about providing compassionate, patient-centered care to the brave patients who have been affected by breast cancer and to assist in maximizing their quality of life. In addition to providing care for breast cancer patients, she is currently co-teaching a weekly exercise class titled Commit to Fit, as well as facilitating and organizing some of Turning Point's monthly educational events. In her spare time, Mallory enjoys horseback riding, hiking with her golden retriever Winston, and indulging in all of Atlanta's fine eateries. Jill Binkley is a program director and founder of Turning Point Breast Cancer Rehabilitation, a nonprofit 501c3 healthcare organization. Jill has extensive experience as a clinician and educator in the fields of breast cancer rehabilitation, orthopedic physical therapy, and manual therapy. She is a certified lymphedema therapist and a fellow of the American Academy of Orthopedic Manual Physical Therapy. She has over 25 peer-reviewed publications and has presented locally, nationally, and internationally on outcome measurement in physical therapy and breast cancer rehabilitation. As a breast cancer survivor, Jill is a passionate advocate for increased attention to the unmet physical and emotional side effects of breast cancer treatment and the role of rehabilitation and exercise in improving the quality of life of breast cancer survivors. Jill is a member of the Oncology and Orthopedic sections of the American Physical Therapy Association and serves on the editorial board of Rehabilitation Oncology. Mallory, I'll turn it over to you.
Welcome, everybody. And I also just wanted to thank Tia and all the members of the My Style Matters organization. I've had the pleasure of working with a few patients who are involved with the group, and they've had nothing but good things to say. So thank you so much for collaborating with us and for taking the time to help facilitate this. Even if it is more delayed than we wanted it to be, we're happy to be here now. And I know that some of you submitted some questions before the presentation. I think you'll find that a lot of those will be answered throughout the presentation, but if not, please feel free in the chat box to jot down any questions, and we'll do the best we possibly can at the end to leave some time to answer those questions. And I'm Mallory, like Tia said. All right, so just some brief overview of what we're gonna cover today. So we're gonna kind of start with a broad overview of some of the common side effects really related to all cancer treatments, and then from there kind of hone in on some specifics related to breast cancer, specifically speaking about fatigue, some of the radiation effects and the side effects that come as a result of that, and then chemo-related peripheral neuropathy, so that's CIPN, that numbness and tingling at the very tips of your fingers or the bottoms of your feet. And then after we briefly discuss all of that stuff, we're going to discuss the role of exercise and rehabilitation in helping to manage and decrease some of those physical side effects that come with treatment. All right, so just a brief overview of the oncology rehab team. Some of the key players that a lot of you are probably familiar with are, of course, your doctors, your nurses. Some of you may have seen a dietitian at some point, social workers or a counselor. And then, of course, we come in as physical therapists and occupational therapists as well. And then massage therapists. We do have a massage therapist at Turning Point once we are up and running again. So I do think it's important to just kind of acknowledge the several members that kind of come together in a comprehensive approach to oncology and cancer care. All right, so Turning Point's mission, like My Style Matters, we are also a nonprofit, a 501(c) organization, and really it was founded by Jill Binkley, who is a physical therapist and breast cancer survivor. And she really identified the need to improve quality of life for men and women going through breast cancer, with the goal of providing, promoting, and advocating specialized and evidence-based rehab. And this care is provided regardless of patients' ability to pay. So it is our goal that nobody is turned away regardless of any financial constrictions. All right, so here's our lobby. We'd love to meet some of you in the lobby someday. So it's our goal that we've made it feel more like a spa and less like a doctor's office. So somewhere where you can come to relax and really take that 45 minutes or hour just for you. Like I said, we do have a financial assistance program, and it's heavily funded by grants, donors, and various fundraising efforts that we have throughout the year. And like I said before, this whole journey that all of you have been on is by no means cheap or affordable. So it is our goal that the financial aspect isn't a barrier to care. And then these are some of the evidence-based services that we provide at Turning Point. That's Lauren, she's one of our physical therapists, and that's our little gym right there. So we do have specialized breast cancer PT, which is what myself and a few other of my colleagues do. We provide lymphedema education, screening, and management. We offer 2 education classes currently. Pilates on Wednesday mornings once we're back and running, and then Allison and I, and sometimes Janae, we teach a Commit to Be Fit class on Workout Wednesday, so feel free to tune in. Right now it's being brought to you virtually, but hopefully back in the clinic once we're up and running. And then we have monthly educational events regarding various survivorship issues, and really we kind of look to the patients and ask them, what do you guys want to hear about and what do you want to know more about? So it can really be tailored to your needs. And then massage therapy and a support group that is led by our counselor, Karen Whitehead. And right now it's specifically targeted for patients with stage 4 breast cancer. All right, a little bit more about us, and then I promise we're going to talk about other things. So Turning Point is also heavily involved in the research world and educating other clinicians. So as a whole, we can provide the most up-to-date and evidence-based care to our survivors. We host a yearly course to other clinicians regarding breast cancer treatment and rehab. This is Kristen Campbell. She's really big in the research world from Canada. So she came down and spoke at our 2019 course. And then like you heard in Jill's bio, we're heavily involved in the research and presenting world. Just a few more quick facts. So since 2003, when we were founded, we have served over 5,000 patients, about 700 men and women each year. And then 20% of our patients do receive that financial assistance aid that we were talking about earlier. And then during all this madness that is called COVID-19, we are providing our services at no out-of-pocket cost to patients. So we understand that the financial burden is hitting a lot of us pretty hard. So we certainly don't want that to be a barrier to our patients receiving the care that they absolutely need. Speaking of the need, that was a nice segue. I didn't even plan that. So there is an enormous need during and after breast cancer treatment, both the physical and emotional toll that our patients are going through. So that's where Jill really identified the need for a place like this. So the research shows that about 60 to 90% of all cancer patients have some type of impairment that is amenable to rehabilitation. So that would benefit from some type of rehab intervention. However, unfortunately, most patients do not receive this care. So that's where we kind of come in and try to fill that gap. The research is quite clear in showing that rehab and exercise is beneficial to many of the impairments that we're going to talk about in upcoming slides. But like I said, unfortunately, many patients don't know that care like this exists, so they're not receiving the care that they should be. So some of the common barriers to rehab, and I'm not gonna read everything, but a few I think that are worth pointing out. There's really a lack of established relations between rehab professionals and then from the medical team. So oftentimes if you were to get your knee or your hip replaced, PT would be an automatic referral. You would be in that orthopedic gym a week or two after surgery, working on range of motion, working on strength to get you back to the function that you were prior to surgery. However, when it comes to breast cancer treatment and surgery, it's not an automatic referral. Although you are getting a part of your body, surgically altered and, repaired and things like that, It's unfortunate that it's not an automatic referral because, like we talked about before, we know that the impairments that these women and men face are amenable to rehab and they can get better. I think another important one to point out is the hesitancy for self-advocacy. So at the point when patients come to us, they have, usually had surgery, they've gone through various treatments, whether it's chemo and or radiation. And oftentimes they think their doctors have been so busy helping to really provide this life-saving treatment that they don't want to, complain and say, hey, I'm having a lot of problems, being able to do my laundry or hold my grandchild or do the yoga class that I like to do before. So they choose to kind of stay quiet and not advocate for themselves. And then I think another one to point out is financial. While this probably isn't the biggest barrier to care, I think it's worth pointing out. Like I said, and as all of you know, by the time that patients get to us, they have well met their deductibles with all the treatments, surgeries, scans, and everything that you've had up to this point. So while it's not the biggest barrier, I do think it's important to know this is a very expensive process. And then I also think last one is the lack of appropriate environment. So say, you come out of treatment, you come out of surgery, and you're looking to get back your range of motion and your strength and, reduce some of that pain, but patients often don't feel comfortable going back to their community gym, whether it's the Y or the LA Fitness. So they don't really know where to go. And then lastly is, while these barriers exist for, kind of across the board in terms of cancer care, I think it's particularly bad in minorities and lower socioeconomic groups and then rural parts of the country. So common physical challenges, again, faced by many patients across the board in terms of cancer treatment are fatigue related to the surgery and treatments themselves, various medications that these patients are placed on, radiation-related issues, which Jill will go into further. Again, that CIPN, that chemo-induced peripheral neuropathy, where there's a lack of sensation, at the fingertips, so patients are having problems fastening buttons or putting their earring backs on, or if it's more on the bottoms of the feet and there's that lack of sensation, they're at a higher fall risk. They're not able to feel where they're putting their feet down when they go up and down the steps, ultimately placing them at a higher risk for a fall. And then lymphedema, which we're also going to cover at greater length in Jill's slides. And then overall reduced mobility and function, range of motion, and then some other things to note, secondary cardio issues and osteoporosis. And each one of these things could be in presentation on its own, but we're going to hone in on just a few for today. So cancer-related fatigue, we'll start there. All right, so really cancer-related fatigue is well documented in the literature. One of the studies found that 70 to 100% of patients, cancer patients going through chemotherapy, reported fatigue as one of the most debilitating symptoms. And it's really considered as a syndrome because it affects everything. It affects your activity level, your mind, your body, your spirit, everything. So it's not just a lack of energy, but it's affecting so many other aspects of these patients' lives. And like I said earlier, it's been identified as one of the most common and distressing impairments that comes from this cancer treatment. And it significantly impacts patients' quality of life. Okay, so this fatigue is definitely multifactorial. So it's usually not related to one thing in isolation, but a combination of things. So whether it's a direct effect of the cancer itself or the surgeries and treatments you've had or chemotherapy, radiation, sometimes all of the above. And then as a result of those treatments come various side effects such as anemia from chemotherapy or chemopause, things like that. Whether it's pain or lack of range of motion from your surgery, stress surrounding everything you've got going on, overall deconditioning as your body's taking all this time and energy to help you heal, your activity tolerance and endurance certainly takes a hit. Nutritional issues, nutrition's a huge component. Are you putting the right things in your body to help you, kind of get over this hump and to help you heal? So I think that also plays a big role in it. And oftentimes patients report to us that this fatigue is so severe that they feel like they're walking underwater the whole time and they feel like they're kind of in a fog and they kind of can't come out of it. So it's incredibly overwhelming. Like it plays into your overall, mental health. It's, can create some emotional stress as well. This fatigue is often not relieved by a quick 30-minute power nap or getting your full 8 hours. It's much more severe and debilitating than that. So definitely something that we want to pay attention to and address. And there are things, I promise we're going to get there. There are things we can do to address it. Just some patient perspectives that Jill quoted in one of her articles. I feel like I've been hit head on by a Mack truck, and many of you probably have said things similar to this, or you can certainly relate to this fatigue and feeling something like this, like these patients reported. There's light at the end of the tunnel. The research is very clear in showing that both aerobic exercise and resistance training are effective in reducing fatigue in cancer patients, both during and after treatment. So whether it's strength training, using some dumbbells, or going for that walk, swimming, whatever you like to do, it has been well documented in the literature as being effective. So the overall approach to fatigue management, again, is multifactorial, and it always needs to be made patient specific. Fatigue is not black and white. It affects everybody different. It's dependent upon all those variables that we talked about in the slides before this. But some things that we usually guide and help our patients with, of course, exercise. And again, you're going to hear that word a lot. Whether it is aerobic, resistance, whatever you enjoy doing is the best type of exercise. Energy management, so thinking about your energy stock in general like it's a bank account, and if you deplete it and go into the negatives, you're going to be paying back that debt. So it's sitting down with our patients and deciding the things you need to do and kind of prioritizing so that you are able to do what you need to do and not depleting yourself after, by 10 a.m. in the morning. So energy management is a huge part of what we do. And then how we can play an important role in pain management, whether it's related to some type of shoulder dysfunction or swelling, something, that we likely can address. And then helping with stress management, whether it's helping you get back to yoga, kind of cueing into mindfulness, meditation. There are some great apps out there that kind of help with the de-stressing. Calm is a big one. I really like it. So I think just kind of helping to center our patients is really important. And then nutrition, whether it's helping our patients advocate to their doctors that they do need a nutrition referral to help tackle that component of it, because it can often be overwhelming. And then what can we do to make you more comfortable so maybe you can sleep better, so you do, feel better. All right, and I'm going to pass it to Jill for the rest of it. So I'm going to stop sharing. All right, it's all you.
Thanks, Mallory. And I'm going to take it from here. Let me just get to the... Good. Can everyone see my screen? Good. So continuing on with a couple of the issues common to all cancers, and then we will get more specific with breast cancer. And we're moving on, just talking about radiation. Radiation, we kind of half kid about it at Turning Point as the gift that keeps on giving. There's a number of issues that we see in breast cancer patients, and as I said, other cancer patients as well. Sometimes an acute irritation of the lungs can cause like a pneumonitis, which is just irritation, inflammation of the lungs. But that's more of an acute thing that goes away. But there can be some long-term effects of radiation on lung tissue. And we bring that up just because it can affect our ability to do exercise. And some people have more significant pulmonary fibrosis. But again, it's just something that we take into consideration from a rehab perspective. There can be some cardiac issues. Soft tissue, I think, is what anyone who's had radiation will talk about first. Radiation affects skin and the fascia underneath skin, as well as muscle in the area. And again, an initial inflammatory response, but later there's an actual change in the connective tissue, in the collagen in the connective tissue. So we do see some tissue tightness. And sometimes, again, without treatment, a progressive loss of shoulder mobility and chest wall tightness can happen up to several years after treatment. It increases our lymphedema risk in all cancers, but that's an important one for breast cancer, of course. And sometimes some neurological damage that can produce neuropathies. And brachial brachial plexopathy is really a neuropathy that really affects the upper limb. And we don't see it very often, but it is something, again, that we occasionally see, and that it's something from a rehab perspective that we consider related to radiation. From a rehab perspective, it may be as simple as adapting an exercise program because a patient may have some issues related to cardiopulmonary function, or even suggesting that they go and be checked out by a specialist and then continue with an exercise program. We have a lot of different techniques and tools in our toolbox to deal with soft tissue mobility and range of motion. Ongoing lymphedema surveillance, intervention for neuropathies, and in some cases, other kinds of cancers, not so much related to breast cancer, but we do see issues that may involve nutrition and speech pathology directly related to radiation effects. So that's kind of just a brief overview. Again, it could be a whole talk on radiation. CIPN, as Mallory mentioned, is peripheral neuropathy, and what we mean by that is numbness, tingling, weakness, and related to chemotherapy. And in the case of chemotherapy, it tends to be on both sides, and it can be either hands or feet. And in breast cancer, Taxol and Taxotere are the two main chemotherapy drugs that tend to be more related to CIPN. When we say it's dose dependent, what we mean by that is that as chemotherapy goes along with ongoing treatment, it can get worse. Generally speaking, it decreases after treatment, but in some patients it does, and it can linger. And there's some things that we can do for that from a rehab perspective. One of a colleague of ours in Michigan has looked at a lot of women that have CIPN after breast cancer, and has found that those women have issues related to balance and increased falls when they have this CIPN in their feet. And again, that's not everyone, but it is something that we consider and we look for in our patients. The kinds of things that we would do for CIPN is, again, exercise. So there's one more for those counting. We do some different kinds of sensitization strategies, balance training, sometimes assistive devices like looking at footwear and what's most comfortable for a patient with CIPN in their feet can be really helpful as well. So now on to the breast cancer. These are the things that, in addition to all of the other things that Mallory and I have talked about, these are some very specific things that we see in our breast cancer patients and that many of you may have experienced. Again, I won't go through the whole list, but the different kinds of surgeries that we have, mastectomy, lumpectomies, axillary node dissection. We know that with more surgery, so mastectomy and more nodes removed, we tend to see more physical issues post-op. Radiation can add to some of those issues, as well as chemotherapy. Depending on patients' reconstruction, which we'll talk about in a bit, the whole area of breast cancer breast reconstruction, as you probably know, adds other kind of unique issues related to problems with the donor sites of tissue and other kinds of musculoskeletal or arm and shoulder and trunk issues. Hormone-based therapy, we're only going to touch on it briefly today, but they can add some unique issues to breast cancer patients on hormone-based therapy. And finally, just recovery advice. We still have patients that we see who may have been told, you know, be careful what you do, don't do too much with your arm and shoulder, it might cause lymphedema. Or don't do too much because, you know, you've had breast cancer and it's not good for you to, you know, overexert yourself. And so unfortunately, we do have women that are still told these things, and that can actually impact that long term. They haven't got moving as fast as they should and may have lingering issues going forward. So some of the common things that we see in our breast cancer patients, pain, reduced mobility and strength, axillary cording, decreased function, and arm and trunk lymphedema. And we will talk about each of these things. We know that the upper extremity issues are really well documented in the research. So it's one of those, you may know it yourself, but this is kind of one of those, and a lot of other women have it too. Up to 66% of women undergoing lymph node dissection or having lymph nodes removed have issues. And even at 6 years out, research has shown this one particular study, but other studies have shown it too. At 6 years, this particular study by Katie Schmitz showed that at 60% of women still had one or more moderate or severe physical symptoms that were amenable to rehab intervention. And as Mallory mentioned at the beginning, unfortunately, most of these women are still not referred for physical therapy. About 20 to 30% of patients develop lymphedema. And so these are all fairly well documented issues. So axillary cording, I think this was one of our pre-webinar questions. Axillary cording is tightness. They have actually done biopsies on this tissue. It's lymph tissue or lymph ducts. They tend to be affected by mostly by having a mastectomy and then having lymph nodes removed. And it seems that the more lymph nodes removed, the more severe the cording is. Although again, it's kind of all over the map. We have patients that have more severe cording but maybe less surgery. So it's not a direct relationship, but you can see it in this woman's armpit. The cords can be very superficial. They can be a little thicker or very fine, like just fine, almost thread-like. They tend to be very painful and really limit patients' range of motion. So as you raise your arm, they tighten. They can also cause pain all the way down to the front of the elbow and to the wrist. We see cording in about we see cording actually in more like 70 or 80% of our patients. And it typically comes early post-op, within a week or two post-op, or even earlier. And as I said, it's painful, but it can also linger if it's not treated and can cause, again, ongoing issues relating to getting that arm over your head. And so it's something that we see in a lot of our patients. In this patient, she's 8 months out from her surgery, so all healed up, but you can still see some lingering issues here that are causing her to have tightness and decreased mobility. So you can see some axillary cording, as well as tightness of that pectoral muscle in the front of her chest, a decrease in tightness in that back of her armpit where it says latissimus. We see that a lot in our patients. And even her incision, it's very tight and doesn't move very well. And that can cause a limitation in mobility as well. So limitations in function, so the ability to lift your baby, carry a heavy load, things that you might do at work, working on a computer, stretching and reaching. Those kinds of limitations have been really well documented in breast cancer survivors. So again, it's not just us, it's across the United States and around the world. These studies have come from all over, and it shows pretty clearly that a lot of breast cancer patients have decreased ability to do their usual activities of daily living after their surgery immediately, which we kind of would expect, but also many times long-term. As I mentioned before, breast reconstruction options can definitely add to some of these issues. When you have an expander or an implant, that goes often under the pectoral muscle, and that causes it's a shoulder muscle and can cause decrease in mobility and chest tightness as well. And some of the other tissue reconstructions where we're using our own tissue, latissimus dorsi is the one in this picture, where you're actually bringing the muscle from the back to the front. And you can only imagine just by looking at the picture, that's going to cause obviously pain, but also it can cause swelling and it can cause reduced range of motion. Some of the abdominal tissue transfers like the tram flap, deep flaps, and some of those other abdominal issues can also cause weakness and tightness in the trunk area. So we do a lot of work with that. Once again, this could be a whole lecture and on reconstruction and the need for rehab after, but just mentioning it, that's one more thing that we consider that adds to these issues. So this is just a slide. I'm not going to go through it in detail, but it's a systematic review. So what they do here is they pull together a whole bunch of studies on looking at when exercise should start after surgery. And long story short, all of this work together from the research world has shown pretty clearly that physical therapy, exercise, so getting back shoulder range of motion and so on, and strength, is a really important piece of the post-op picture, and does result in getting improvements in shoulder range and strength. So our approach, if you came into TurningPoint or a physical therapist specializing in this area, obviously we look at shoulder, arm, and trunk range of motion, ideally early post-op, like that research that I just mentioned. We may use manual therapy and soft tissue techniques to gradually stretch that tissue, and whether it's post-op, as long as it, in certain healing phases. It's also manual therapy and soft tissue techniques are things we do after radiation as well, and sometimes during, depending on the tissue. Strengthening, aerobic exercise, helping patients get back to their usual aerobic exercise, walking, running, whatever they like to do. And obviously education is a big piece of what we do regarding just getting back to usual activities and function. So lymphedema, this is at TurningPoint. This is our parameter that we use to measure lymphedema by measuring arm volume, and comparing your affected and unaffected side gives us an idea of arm swelling. So talking about lymphedema, first of all, just to define it, it's a chronic progressive disorder. So unfortunately, when we get lymphedema, it doesn't go away. It's an impairment of the lymph flow from our tissues just under the skin, usually related to damage in the lymph system. And in breast cancer, the damage is caused by, or the changes in flow are caused by the removing of nodes in the axilla or the armpit, as well as radiation, which specifically actually affect lymph nodes. So that is a issue. And it results in an accumulation or a backup of lymph fluid from that interstitial space just under our skin. And if it gets severe enough, then we start to see visible swelling. So the risk factors are really well documented for lymphedema in breast cancer patients. It's basically the number of nodes removed. So as the number of nodes goes up, unfortunately, our risk for lymphedema goes up. Radiation therapy is also a risk, especially if it's done in that armpit area, which most breast cancer patients, at least, radiation affects some of those axillary lymph nodes. BMI of greater than 25 is a risk factor, as well as a specific trigger that has been identified in research. If someone has an arm infection or a specific injury, because it brings fluid to the area, it doesn't actually cause lymphedema. The causes are the first 3 bullet points, but can actually trigger the onset of lymphedema. So a lot of research has shown that early detection and treatment of lymphedema is really crucial. It can keep lymphedema at a very low level and also reduce the progression of lymphedema. So patients ideally should have a baseline volume measurement, ideally pre-op, although to be honest, it's hard to get patients to us pre-op, but we try. Or early post-operatively when people first come in after their surgery. By having these early measures, it allows for detection of very minor changes in arm volume so that we can detect it early and then treat it early where we're most effective. So some of the signs and symptoms of arm or hand lymphedema a lot of patients may begin to feel or sense lymphedema with a feeling of tightness or fullness or heaviness. And the heaviness is key because some research has actually shown that that feeling of heaviness in the arm is a very key feature of that early lymphedema, possibly even before we can visibly see it. So we always let our patients know that if you start feeling these kinds of things, be aware of that, give us a call, come in and see us. Some patients find that rings, watches, bracelets become tight. Swelling may appear during the day when the arm's down and then diminish overnight when you've got it kind of up at shoulder and body height as you're laying flat. Decreased visibility in the veins on the back of the hand, and a greater roundness or fullness of the elbow, wrist, or forearm. And you can see in this picture on the left hand, just not this is more significant lymphedema. I wouldn't consider this super early, but I needed to make a picture where you could see it. The difference between the little folds between the knuckles, you can see that they're filled in with some puffiness. And on the left hand, the tendons of the left hand aren't as visible, and there's some filling in of fluid between them. So those are the kinds of things we look for in the hand and arm. Stemmer sign is picking up the skin on the back of one of your fingers. If you can pick it up, generally speaking, you don't have lymphedema. It's not kind of a definitive, but when it gets puffy, it becomes hard to pick up that skin. The knuckle check we just talked about, looking at forearm tissue and bony contours of our elbow being filled in. So we look at sort of patients with, the hands as well as the arms outstretched. And just some things for you to look for as well. We also see lymphedema in the trunk and the breast. In trunk lymphedema, it's a little more common after mastectomy, obviously, versus lumpectomy, but also with some of those abdominal reconstruction procedures that I mentioned. It can feel like pressure around the lower rib area, and sometimes people with trunk lymphedema feel that those pants or that waistband that you put on in the morning that fit, it gradually feels tighter by the end of the day, and that can be an indicator of trunk lymphedema. In the breast area, we do see lymphedema that's fairly commonly in patients that have had lumpectomies. And it can also feel like kind of that pressure in the chest area, or that a bra feels more uncomfortable or tighter at the end of the day. And so those are kinds of things that we also pay attention to and help patients manage. So what's involved when you get lymphedema? What do we do with it? It depends on the patient, but it will probably always involve some form of compression, and the patient in this picture has a sleeve and a gauntlet on. It will definitely involve exercise. Manual lymph drainage may be included, weight management if that's appropriate, and then avoiding potential triggers or things that could make it worse. Some of the things that we teach our patients, and this is all based on research that we have pulled together to be, what do patients need to know who are at risk for lymphedema? It needs to be based on individual risk. A patient with one node removed and no radiation, the risk is very low for them versus a patient with many nodes removed that's had radiation. And so when you go online and Google lymphedema, but if you don't understand your specific risks, it can be very scary because they're not necessarily dividing out and making it unique to you, whether you're at risk or not. So those early signs and symptoms, we want everyone to know those so that we can get patients into early intervention if we need to, and also using those baseline measures to allow early detection. Exercise has been shown to decrease our risk of lymphedema, and we also use it for a treatment when patients do have lymphedema. Exercise helps to pump out that lymph fluid, and the skeletal muscle in our upper extremity and our arms is really important part of that pump of lymph fluid. Ideal body weight and diet hydration can be an important factor. And finally, just understanding potential triggers. If you go out and do an exercise program, you start an exercise program, and you're someone who's at risk for lymphedema, then lifting and exercise is good, but we don't want you to start with 150 pounds. We want you to start slowly and work up, because an injury like a sprain or a strain can actually again bring fluid and an inflammation to that area and be a trigger, or even and actually be a trigger for lymphedema rather than a help for it. So it's important for people to know that slow and easy, but it is important to do. Avoiding infection and inflammation. And what we mean by that, it's sort of hard to say just avoid getting an infection, but if you cut your finger or you have a hangnail and it looks like it's irritated, just getting a little Neosporin on it when you might not have been too concerned about it on the other side. Wearing gloves while you're gardening can just help protect from those kind of triggers that are infection and inflammation. We aren't going to go into the details of flying, but sometimes that has been talked about as a risk factor for lymphedema. And the research really shows that it's not a risk factor. But when our patients are going to be away from us who are at risk for lymphedema, they may, and they're going to be traveling, we may suggest that they take a sleeve, so that really, not that the flying is a problem, but that if they're away from us and they need treatment, they have a compression sleeve to use for that early treatment that we talked about. So cornerstones of our approach to lymphedema at Turning Point, those baseline measures and surveillance, education and individualized risk factors, and an ongoing approach to lymphedema management that's individualized. One size doesn't fit all. Some patients need different kinds of approaches that fit in with their lifestyle and their work and their activities. And it's always evidence-based. We're always looking for current research to guide our treatment. A couple of slides on hormone therapy, and then I'm just kind of watching the time as well, because we want to make sure we have time for questions. Again, it could be a whole topic, but patients with on tamoxifen, these are some of the side effects that we see in our patients, and that can be significant impacts on quality of life. And specifically on the rehab side, hot flashes can mean that patients aren't sleeping properly or sleeping well. They can also affect their ability to do exercise. So these are things that we would be talking to about with our patients and referring for other kinds of providers to help with some of the other side effects of tamoxifen. The aromatase inhibitors for postmenopausal women bring with them more musculoskeletal issues, specifically increase our risk of osteoporosis and also joint pain or joint arthralgia. So it's not uncommon on the aromatase inhibitors to have pain and discomfort in the small joints, hands, feet, knees. And these are things that we can work with patients on from the rehab point of view, and also help guide them back to their oncologist when these issues are severe. So they're just something that we, again, are in our realm and in the back of our mind as we're caring for patients on these different kinds of treatments. So just kind of getting to the summary part of, so when we look at all of these side effects of treatment, as Marilyn said at the beginning, we do talk about exercise a lot, and there's a lot of research to support the benefits of exercise related to all of these kinds of things we've talked about. So it decreases our risk of recurrence. In patients with ER or estrogen receptor positive breast cancer, up to 50% reduction in our risk of recurrence. And when you think of that, that's as important as many of the treatments that we have. So that's a big factor that not everyone realizes how important that is. After we're finished our treatment and we begin to worry about, will this come back? That's one of the things that's in our control that we can actually take care of. Reduces fatigue, decreases our lymphedema risks. And when we have lymphedema, it reduces that lymphedema. We use it as a treatment. improves range of motion and function, bone health, and it's an important component in the management of CIPN that we mentioned today, as well as those joint pains and arthralgias that are related to aromatase inhibitors. So timing of exercise and of rehab and exercise, I'm going to skip over this, and basically suffice it to say, there is a lot of research to support early and prospective approach to some of these issues we've talked about. By identifying them early and addressing them, they're much less impactful in the long term. So let me get to what we can do for you. So this is going back to the same slide that Mallory showed you, and these are the kinds of things that programs and services that we have at Turning Point, and normally before COVID-19. So we offer, a wide range of specialized programs for women and men going through breast cancer. And now most of these are offered in our clinic usually, but also via tele-rehab. And we have some special things going on to support our patients during COVID-19. We've gone virtual, like education events like today. And we're actually doing almost all of our appointments with patients via tele-rehab. And so we have a HIPAA compliant Zoom platform where we're actually seeing our patients and assessing them and coaching them and providing care remotely. We are seeing a few patients in the clinic, but most of our patients are being seen via tele-rehab. It's kind of pushed us to platform. Tia and I were talking about this when we came on, pushed us a little earlier than we expected, but it's going really well. We continue to have our emotional support programs remotely, education programs. We have one tomorrow actually, and I'll give you some information on that, but we're also doing them remotely. Keeping in touch, we're reaching out to our current patients, making sure they're doing okay. We realize patients going through both breast cancer at this really difficult time, it's really important to provide that support that they need. We're also doing exercise classes, as Mallory mentioned. Our Facebook has both exercise snacks, short little exercise bits, as well as workout Wednesdays on our Facebook page. All of this care that we're offering during COVID-19 is being given at no out-of-pocket charge to our patients. So it's something that everyone can access at this point with no charge. I think I've covered this, but by going to remote access and tele-rehab, we're actually embarking on a program to serve patients, not just in our sort of greater Atlanta area, but across Georgia with some new programs. So anyone can access our programs there. If you go to our website, I'll have that in a minute. You can reach out by email or phone. And I think it's probably more important to put up our website in just a second so that you can reach us. We do happen to have one of our education events tomorrow. Lisa Isley, our dietitian, will be talking about anti-inflammatory eating and good diets. And this is how you can access all of that I just mentioned. If you go to myturningpoint.org, at the bottom of the homepage, there's a section called Blog and Latest News. And if you click on any of these, tomorrow's event is under nutrition, and we would love to have some of you join us for that. Thank you. And we do have some time for questions, so.
Sorry, I got put on mute again. Thank you so much, Jill and Mallory. We did get some questions in our chat, and so I'm going to go ahead and read off those questions that are in our chat. Let me scroll down. Can only patients access the tele-rehab? Jill, are you able to?
Yes. So I was looking at the chat. I'm just going to listen to you. Sorry about that.
Okay. That's all right.
So tele-rehab is done, it starts with physical therapy, and Yes, you need to be one of our Turning Point patients to access it, because we need a referral from your physician to actually provide direct support and care and advice. However, it's not easy. It is easy to do that. If you just reach out to us with the contact information I provided, or I can send more contact information to you, Tia. We just need a physician referral. Often we're actually the ones that call the physician to get that referral. So by reaching out, you become one of our patients. So as long as people don't mind that, yes, you can access it that way.
And does it matter where they're located? Because we do have some people in different states as well.
Different states depend on the state. We can't actually care for and treat patients from out of state. However, we do have some colleagues that are working with us on some of our outreach that we may be able to care for a patient. So I would suggest they give it, outreach to us, and we will take care of it from there.
Okay, awesome, perfect. Next statement. I was treated at Turning Point 2 years ago. I've been experiencing some symptoms mentioned for chest lymphedema. How do I go about returning for treatment?
So same thing. If you could just give us a call. So I see some people are asking about contact information, and I think I can put up a slide with the number, but let me just give it as well. So it's 770-360-9271 or staff@myturningpoint.org. But again, we can get this out to you, I think, through you, Tia, as far as more contact information.
Awesome, thank you. And we will send a follow-up email to all of the attendees, along with the person who won the drawing once we do the drawing. The next question is, what are the natural remedies that you can take to decrease inflammation on AIs?
So certainly the whole nutrition aspect is a little bit outside my scope in an area where I'm not 100% confident, but that's why it's nice that we do have Lisa to, be able to refer patients to, or to reach out to her to ask questions. Just kind of speaking from clinical experience, I have had some ladies that are taking turmeric, and I know that kind of helps decrease the inflammatory markers in your body, whether they're taking it with a pill or a powder. I have some lady that takes it with milk. Can't really speak to that personally, but so just speaking clinically, that is one of the tips that my ladies have told me in our sessions.
Yeah. Another question. I find that it is easier for me to become short of breath with exercise. Is it possible to reverse this, especially since I took a test that showed decreased lung function, which I presume was caused by radiation treatment?
So it could be caused by radiation treatment, and that's something that we mentioned. And as I said, we don't see it in a lot of our patients, but we do see it. And it's something that I would like to talk to the person about very specifically. I'm happy, it doesn't have to be a patient interaction, but ongoing, just continuing to exercise at your level and gradually increasing is really the kind of prescription for decreased exercise tolerance. But it may be something that we can work with really specifically with the physician, and knowing the test results and that kind of thing would be something. And it doesn't need to be an ongoing intervention with Turning Point over weeks and weeks, but definitely something that we would love to talk to you about, and is definitely worth pursuing with one of our PTs.
Awesome. And the last question was, what's the dietitian's name again?
I can do that. Lisa Isley.
All right. Does anyone else have any other questions? And I'll give them a few minutes to add any other questions in the chat, just in case we have additional questions. How many times did Jill say exercise? So that was a question to Marlena. All right. I think that was an inside joke. All right. I sent a question in my email registration. Is it possible to? I think so. She's still typing. Pull that from the registration. Okay. Let me see. If you're able to post the question, that'll be great. That way I don't have to jump out and jump back in. So if you're able to post the question that you submitted in your email registration, that'll be good.
Tia, would that be the same list that you sent me, or this could have been added after?
Yeah, after, yeah.
Someone asked about swimming. So while you're typing your question, I'll answer that question. I'm just looking at the questions you sent me. Oh, there's a couple of questions we haven't addressed. Swimming, yes, great exercise and definitely could help with lymphedema. It's a great, you're using your whole upper body, but you're also getting the additional part of the whole lung, the breathing part. It's an excellent exercise for women with lymphedema, or in terms of initially even decreasing our risk of lymphedema by exercise. So yes, it's great. On a side note, there's actually some studies that have shown that water aerobics is a great intervention for people with lymphedema. So that's just a side thing. Someone asked about being a year out and having numbness in their arm. It's really common, and we didn't mention that a lot other than that CIP and the numbness and tingling. A lot of patients have numbness in that whole area under their armpit. The chest wall may be numb. And what we find with most people is that if the area, with time, that area that's numb tends to get smaller. And then there's probably still, unfortunately, going to be some numbness. But if it's significant and it's impacting you again, we should probably have a look at it. But that numbness in that area is pretty common and normal. And the other thing that happens with time is you stop noticing it as much. And I think it's because your brain kind of fills in and it becomes your new normal. But if it's really significant and impacting you, again, we should probably have a look and discuss it.
Okay, I have the question pulled up. So I have an upper extremity and axillary lymphedema as a result of my surgery. I know that there is at least one scientific peer-reviewed weightlifting routine shown to help with this. Do you know how I might get access to this routine to use with a trainer?
So
I can repost.
I've got it. I see it. I have half an answer for you. There isn't just one exercise routine that's been shown to be helpful with lymphedema. There's a lot of studies that have shown to be good for lymphedema, and it's basically, they all involve progressive resisted exercise. So starting slow and gradually increasing the exercise. So it's more, as opposed to being specific and prescriptive, there's definitely some pointers or guidance that we could give, and I'd be happy to share that. We could pull that together and with some of the research that's been done. But the person to look for, if you're digging it up, is Katie Schmitz, who's done a lot of work in this area. If the person wants to reach out to me, I think it's April, I can put my email address here. We're all trying to figure out this technology, so.
And we'll also, like I said, when we send out follow-up communication, we'll have all of the information for Turning Point in there. I was just making sure there are no other questions that were submitted. Does anyone else have any other questions before we close out? All right, we got one more posting in the chat. That was just your email. Okay. All right. Well, I want to thank everyone for their time. And hopefully you found that this workshop was helpful. We will ask if you can provide any feedback that you have on this workshop. We want to continue to do more workshops to educate you around the disease and things that may have affected you after going through or while going through your cancer journey.